Good morning, everyone. Today, we all are gathered here to discuss on the topic of bone marrow trephine biopsy, indications and relevance in the current era. I would like to take this opportunity to welcome and greet our program director and moderator, Dr. M.B. Agarwal, sir. We all know him. We all know what he has established in this field and how he has inspired many and how he is the teacher of the teachers, as we call him. And we all are fortunate to have him. He has also been awarded by the Inspiring Hematologist of India by ET and also awarded the Guru Dronacharya Award by Indian Leukemia Academy. So thank you so much, sir, for providing us this platform where we can have these enriching discussions. I would also like to welcome our today's guest speaker, Dr. Basu, and he's a professor in Department of Pathology, Mahatma Gandhi Medical College and Research Institute, Puducherry. So welcome, sir. And now I would request Dr. M.B. Agarwal, sir, to take this up and take the session forward.
Thank you. Good morning to one and all from India. Good afternoon, good evening from those who have logged in from the rest of the world. As was mentioned, our guest speaker today is Dr. Devadatta Basu from Puducherry. He'll be lecturing on bone marrow trephine biopsy, indications and relevance in the current era. Medicine evolves, and even if you have learned your bone marrow biopsy indications and relevance in your early days, the things may be very different from 2025. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS, managed by Perfect Square. I thank Dr. Manoj Kumar and his team from INTAS for supporting our academic activities, Mr. Yash Kalpesh and the team from Perfect Square for flawlessly managing these shows, the Executive Committee of Mumbai Hematology Group that has been very supportive in allowing me to conduct these webinars, our chief guest today, Dr. Roshni Pandey, grateful to her for sparing her Sunday morning. Our guest speaker, of course, who is the hero of the day, Dr. Devadatta Basu from Puducherry, keeping the torch of hematopathology going on shining and updating it every few months for us. All our discussants who are either eminent clinical hematologists or hematopathologists. And you participants for sparing your Sunday morning, afternoon, or evening. Coming Saturday, 15th March, 7 p.m. IST, we have Dr. David Tichai. He is from Pennsylvania. He is pediatric hemato-oncologist, and he's going to tell us about childhood ALL management in 2025. Next Sunday morning, 11:30 a.m. IST, we have Dr. Campello from Spain speaking to us on an update on myelodysplastic syndromes. Discussants today, and I was telling Dr. Basu, there is an overwhelming response for people to join as discussants. So we have a galaxy of them from all around. I'll quickly go over their names. Dr. Abhishek Purohit, Dr. Akshaya Mandloy, Dr. Amit Khurana, Dr. Amrita Saraf, Dr. Anju Bharti, Dr. Arihant Jain, Dr. Ashwini Panigrahi, Dr. Avinash Gupta, Dr. Avinash Singh, Dr. Debadrita Ray, Dr. Deepa Rani, Dr. Deepak MB, Dr. Gurpreet Kaur, Dr. Ifat Jamal, Dr. Jyoti Saine, Dr. K. Gayatri, Dr. Kazumi Patel, Dr. Kanan Sood, Dr. Manjusha Ray, Dr. Mayur Nirulia, Dr. Meenu Angi, Dr. Meera Vardarajan, Dr. Neha Kamble, Dr. Piramal Sarda, Dr. Rashmi Kushwaha, Dr. Richa Juneja, Dr. Ruchi Gupta, Dr. Ruchi Khanna, Dr. Shashi Bansal, Dr. Shivani Joshi, Dr. Srinidhi Nathani, Dr. Shubham Goswami, Dr. Suresh Hangawadi, Dr. T. Rama Devi, Dr. Tejasvi Gudubande, Dr. Tushar Mittal, Dr. Udyan Kachi, and Dr. Vipul Sheth. Dr. Devadatta Basu does not require any introduction. Even before these webinars started, he was a huge and well-known personality in the field of hematopathology, a teacher par excellence who has updated the field by leaps and bounds and taught hundreds of students all around who are practicing today hematopathology in this country and abroad. But this is just to complete a formality. He has been our speaker at multiple occasions during these last 4 to 5 years through the webinars. At present, he is Professor of Pathology at Mahatma Gandhi Medical College and Research Institute, Puducherry. He did his MBBS in 1985 from Maulana Azad, MD Pathology 1990 from the same institute. As we all know, he was former professor and head of pathology at JIPMER, Puducherry. He is fellow of the Indian College of Hematology. His publications, 239 and maybe much more today. His interest is in the field of hematopathology and medical education. And it's a part of this medical education that he's here today sparing his Sunday morning. As was mentioned, he will be teaching us about what are the indications and relevance of bone marrow Trephine biopsy in 2025. Our special guest who will be inaugurating this webinar today is none other than Dr. Roshni Pandey. Her enthusiasm can be described that there is hardly any webinar on Saturday or Sunday during last 4 to 5 years when she has not been a part of our either faculty or discussant. She's a consultant medical oncologist, Marble City Hospital, Jabalpur. With a view to serve rural India, she opted for doing MBBS from Mahatma Gandhi Institute of Medical Sciences, Sevagram, over Grant Medical College, Mumbai. After this, she did DNB in pediatrics from Apollo Hospital, Chennai. Subsequently, she worked for a year in HIV clinic at the BJ Wadia Hospital for Children, Mumbai. She was NCI fellow at TMH, Mumbai in 2000. Her first connection with Mumbai Hematology Group was in the form of participation for Dr. J.C. Patel Best Paper Award 2000. She did residency in pediatric oncology at TMH Mumbai. However, she was convinced by the stalwarts to complete rotation adult oncology as well. She got trained in clinical trial methodologies also. She has numerous publications and has presented various important papers both at national and international level. She is recipient of the award at SIOM. From 2004 onwards, she occupied faculty position in the Department of Medical Oncology at TMH as pediatric oncologist and BMT physician. After marriage, she shifted to Jabalpur, and this was in 2006. Since then, she is practicing as a consultant medical oncologist at Mahakoshi Hospital, Jabalpur, which is a private institute. She is a certified medical oncologist there. Her areas of interest include hematolymphoid malignancies and pediatric cancer. Despite all the challenges faced in that part of the country, her goal has been to reach out to the poor patients, guide them through their treatment at the medical college, and provide them accurate diagnosis and offer them standard of care. Well, Dr. Roshni, go ahead and inaugurate this webinar and give us some words of wisdom. I'll stop here.
Good morning, sir. Dear teachers, colleagues, and friends. I thank Dr. M.B. Agarwal and MHG for inviting me for today's webinar. Extremely honored and humbled to be amongst you all. I have been blessed to work with the stalwarts in hemato-oncology at the Tata Memorial Hospital, Mumbai. I learned not only the science, but also the art of practice from them. My teachers never admonished me when I made mistakes or asked questions. On the contrary, they always encouraged me by saying that had I not been working in the wards, I wouldn't have made the mistakes, and then I wouldn't have learned from my mistakes. They always stood up for me. My mentors instilled me work ethics and passion for my craft. They led by example. Advani sir would always ask us if we had gone to the lab and seen the slides of the bone marrows we had done on our bone marrow duty day. Since we were always short of residents, on many occasions we missed doing this. But after coming out into the real world, I understood the importance of what he said, and the dialogue between the clinician and the pathologist cannot be understated. Apart from taking care of patients, which I'm sure you all do so well, it is important to maintain records. Today's times are difficult. Patients are suspicious, may have trust issues, seek multiple opinions, and get confused. All our efforts, our education, our dedication would be wasted if we are not able to protect ourselves when it comes to litigation. It is important to keep on talking to patients and their families to avoid distrust and spread of misinformation. Treat your colleagues with respect. Weigh your words carefully when patients come to you for a second opinion. It is best not to criticize the previous doctor, even if one may not totally agree with the advice or treatment given. For those who are pathologists and who have done their DM in clinical hematology, get some basic training in medicine, as you may not always have a backup good physician available, and each consult to another specialty costs the patient money. Of course, it is important to take timely help when warranted instead of being overconfident or egoistic. The tier 2 or 3 cities in India are still very short of trained hematologists, oncologists. Working in these places is a continuous challenge, but not impossible. Here, flow, cytogenetics, immunohistochemistry, and PET CT is not easily available. So, clinical acumen is of utmost importance. Having had no option myself, I still feel that for women, institutional practice is the best balance between professional commitments and personal commitments. Post DM, try to work in another high volume center to get a different perspective before venturing out on your own. And always remain in touch with your teachers and friends. I know that whenever I needed help, I reached out to my teachers and friends, and through discussion, I was always able to find a way for my patients. My focus in Jabalpur, as Sir has said, has been on correct diagnosis, even if it meant sending patients outside to complete the investigations properly. Never compromise on this. Patients never run away. In fact, they trust you more and when they see that you never compromise on quality of care. Education is the most important weapon, and life is a continuous process of learning. Dr. M.B. Agarwal sir has made this a reality for all of us through the virtual webinars, especially for people like me who find travel costly, as much of my leukemia and pediatric work is free of cost. No professional charges from my side. I wish you, each one of you, personal fulfillment and happiness in your journey, and strive to impart excellent healthcare to the people of your countries. Hematology is an excellent branch, keeps you mentally agile, but also very demanding. So take care of your own quality of life. Innovate, persevere, mentor, inspire, research, and publish. Only the sky is your limit. Bless you all for a bright future, and looking forward to meeting at least some of you in future conferences. If you love what you are doing, you will be successful. I end by quoting, success is not how high you have climbed, but how you can make a positive difference to the world. Good luck to all of you, and thank you, MHG. Thank you, sir.
Thank you, Dr. Roshni, for that very powerful, brief, but an important speech full of messages. You have been following the Gandhian pathway, serving for the poorest of the poor. This was a very important message which you have put across. I remember my professor telling me, one patient per day, make him totally free, don't charge him. And we've done that as what you said multiple times because we need to help our fellows in this country. I have to mention one thing about you. Any conference when you come, there has been no lecture where you didn't have a question. Similarly, in any of the webinar, I've been telling people, all the discussants, that kindly prepare at least 3 questions so that you have something to ask to the speaker. And here you are. You have put up the raise hand sign even before the lecture gets over so that you're the first one to ask the question. And then you have got very well drafted 3 questions ready for every lecturer. And those questions have been very thought-provoking because they have been probably difficulty of everybody. So, Roshni, you have been a very, very, very active person on these webinars. Thank you so much for contributing. And today, it was a wonderful speech. Thank you.
Thank you, sir.
And now, all over to Dr. Basu. Now we will listen to you for the next 45 minutes.
Okay, thank you so much, sir. And that was really wonderful, Dr. Roshni. I'll have to prepare myself for the 3 questions that is going to be charged at me. Fine, thank you very much. I'll share my screen and we'll get started. Is it visible?
Yes.
Yeah. All right. So I'll. No, it's not moving. One sec. One second.
Take your time.
Yeah. Right. So is it now visible and am I audible?
Yes.
Usual question. Right. Thank you. So to all of you, the process, what I'm going to discuss today is the process of bone marrow trephine biopsy. Bone marrow trepanning is a kind of an ancient procedure. Drilling a hole into the skull has been reported in the medieval Europe as well as in Chinese people. That time it was probably mostly due to therapeutically for treatment of headaches and treatment of mental illnesses. The diagnostic utility and its relevance in the current era is what I'm going to talk about. And the history of bone marrow examination, if you look at the literature, came first way back in the early 20th century. In 1905, we have reports of a bone marrow biopsy being done in leishmaniasis. The bone marrow aspirate technique of the sternal puncture came about a bit later in the Russian literature. And the history of my journey with bone marrow trephines began in 1988, the year I joined as an MD pathology student at Maulana Azad Medical College, when Dr. Tejinder Singh, my guru, handed me over this particular needle. This needle that you see was handed over, and I did the thesis on a bone marrow biopsies. Along with the experience that I got from my teachers in MAMC, a couple of literature, 2 books especially were very useful. This was my Bible during my thesis, Frisch and Bartels bone marrow biopsy. And currently, I still have this Barbara Bain's bone marrow pathology at my desk to refer to at any point of time. The articles that I have kept here are, though old, but form a very important tool in my learning. So along with my teacher's teaching and the literature, the experience that I gained in JIPMA over the last nearly 30 years of 13,597 biopsy will form the basic core of today's talk. And we will discuss how bone marrow biopsy has evolved over the years in our understanding of diseases. This is a quote that I like very much from Barbara Bain. A request for bone marrow aspiration and biopsy should be regarded as a request for a consultation on the patient in question and not simply as a request to carry out a technical procedure. This is true for both the clinicians and the pathologists when you are looking at a bone marrow. It's like consulting a patient for a disease. And as you know, the bone marrow in a child is practically all over. Whereas in the adult, it's centripetal with the long ends of the bones, the long bones, the upper end of the long bones, and the flat bones, which are a rich source of marrow. I'll start with the indications of bone marrow examination, what textbooks have told us, what we generally practice, and then we will see whether these indications remain the same or what has happened to these indications. So let's go one by one. Investigation of unexplained anemia, abnormal red cell indices, cytopenias, and cytosis. Could be leukocytosis, leukopenia, thrombocytopenia, That's one of the investigations. When we have an unexplained, that is the key word. When routine investigations or other investigations are not helping us. Investigation of an abnormal peripheral smear morphology, suggesting a bone marrow pathology. The first thought that comes to mind is a blast or a teardrop cell. That situation, we do a bone marrow. Then probably the bulk of bone marrows that we do today are for hematolymphoid malignancies, for diagnosing, staging, as well as follow-up. And it could be any of these malignancies that we have. Investigation of suspected bone marrow metastasis, unexplained focal bony lesions on radiology, unexplained organomegaly or presence of lesions or masses inaccessible for biopsies or aspirates, where we need to do a bone marrow, suspecting, again, hematolymphoid disorders, evaluation of iron stores, investigation of storage disorders, microbiological investigation for a patient with PUO, or when you're looking at very specific infections like leishmaniasis or disseminated tuberculosis or malaria, and exclusion of hematological disease in potential allogenic stem cell transplant donors. So with these indications, we know that there are two techniques, an aspiration and a trephine biopsy. We also know that aspiration is an easier technique, more popular technique, and trephine biopsy needs a bit of technical expertise or technical finesse. Okay, this is a question for all of you. I know I won't get an answer right now, but maybe on the chat. That's a patent of an Iranian physician. Name the person or the instrument. You can, okay, so this is actually the patent of Jamshidi, Khosrow Jamshidi, and that's the Jamshidi needle which we use for the trephine biopsy. Notice that the tip is slightly smaller in diameter than the entire needle, and that is the reason for that is the biopsy, when you're pulling out or pushing out the biopsy from the needle, it has to be always pushed through this up from this side posterior. The biopsy should not be forced out of the proximal end because that causes crushing. So this is the beauty of this needle, how it was developed, and most bone marrow biopsy needles have this little fixture that the tip is narrower than the body of the needle, and that's important for us to know. So we have these needles, the Sala and the Klima used for bone marrow aspiration, and the Jamshidi and the Western Manjensel. This is the needle that I was inducted into, but it's a good needle, a long needle, scary looking, but it's worthwhile. We all know the sites of the bone marrow. It's currently posterior superior iliac spine is the standard site that has been advised and that we do. Once upon a time, sternal punctures used to be done, especially for aspirates. We no longer prefer sternal puncture, and if you are going to do a biopsy, it's a strict no-no. Only in small infants is tibial tuberosity as a site of biopsy because the cartilage is not so much there. Bone marrow aspirations are technically easy with a quicker turnaround time, hence more popular. And we make smears. Good smears like this are really good. You know, you can make it as a wedge or a crush or a simple. Both these are good with lots of particles. So if you have a cellularity like this, you can do wonders with it. You know, diagnosis is not a problem. But my first case that I will discuss is a 59-year-old male with backache and severe anemia. He had hemoglobin of 6.5, total count of 3,600 and a platelet of 30,000. And the peripheral smear is giving you some dead giveaways. As I said in your indication, abnormality on the peripheral smear, teardrop cells, occasional NRBCs, and you have this leukoerythroblastic blood pictures. So you go ahead and do an aspirate, right? However, the aspirate is diluted. You have a few nuclear RBCs, erythrocytes, erythroblasts. You have these myeloid cells, nothing more. So you do have what is called a dry tap. So what do you do when you have a dry tap? What are the possible causes? Most of the time, I feel it's technical. We've not got into the marrow properly. However, those situations where there are no marrow elements like fibrosis or aplasia, you tend to get a unsuccessful aspirate. We'll discuss about this in a little while, how aplastic anemias can still be picked up on an aspirate. Or the marrow, they say, is very cellular and packed, and the negative pressure is not able to pull out all the cells, or there is some pathology in the bone. So in all these situations, which is either aplasia or fibrosis or focal lesions, you know, if your biopsy or if your bone marrow has focal lesions, you know, if you do an aspirate from here, you're likely to get a normal marrow. So that's another situation where a biopsy helps. Or your pathology is in the bone trabeculae. All these are causes of a failed aspirate. Failed in the sense that either you don't get any material or you get material which is not representative. So generally the tradition, what we do is we do a simultaneous aspiration and biopsy. Which one to do first? It's entirely your preference. I prefer to do a biopsy first. Whatever it is, you remember there will be some hemorrhage in the subsequent procedure. So I prefer to do a trephine, but it's very, very important that our point of entry into the bone is separate. Your skin incision is the same. You go put in the needle and see to it that you at least 1.5 to 2 centimeters at your entry into the bone. When you pierce the periosteum should be at least this much away from each other. Hence, it's very, very important that when we are giving the local anesthesia, we give a adequate area we cover with the local anesthesia. And it's preferred to use separate needles for both. If your aspirate fails, you've done an aspirate first and it's not very good, or get into the habit of making imprints. Imprints are made by either rolling it or by pressing it on between two slides. And it's very useful because it gives you kind of a trailer of the Trephine biopsy, and the yield is often much better than an aspirate. At times, your biopsy material clots. What you've gotten, you get a clot. I remember the very first bone marrow that I had done, I got a nice long piece of a clot, and luckily we were told to put it into formalin, use it as a histopath specimen, and you get good results. This is important. Processing of a Trephine is important. We follow the Hammersmith protocol, courtesy Dr. Naresh. It consists of a fixative which contains a decalcifying agent, a weak acid, acetic acid, zinc, formalin fixative for 24 hours, followed by formic acid and formalin for 6 hours. This is a good, very good decalcifying agent, doesn't alter the morphology much. EDTA is also a good decalcifying agent, but it takes time to decalcify an EDTA. And with this Hammersmith protocol, our turnaround time, we kind of brought it down to almost half. And if you follow up the biopsy personally well, you can report off a Trephine within 48 hours, as early as 48 hours. All stains, histochemical stains work. Immunohistochemistry works very well. You can subject it to molecular studies also. So let's start at the very beginning. This initial part, I will just discuss a bit about how to approach a bone marrow aspiration and biopsy. Needless to say, you need these information at the start of your thing. When you are reporting on a biopsy, please see to it that aspirate report should be available. In many places, including where I started my work, the aspirate would be reported by the hematologist and the biopsy would be reported by the histopathologist, and often there was a clash. So that should not happen. Whoever is reporting the aspiration should have the clinical details, the peripheral blood report, reticulocyte count, and do the biopsy at the same place. Adequacy is important. Remember, during this processing, about 25% shrinkage occurs, so need a good length with at least 5 to 6 trabecular spaces. Cellularity assessment, again, I need not tell you that it varies with the age. So what is, we can look at the particles to say what the thing is. Always look at the age of the patient. Roughly 100 minus age is the thing, but generally in an adult from 30 to 60 years, it's about 50% is a good cellularity. This is how we look at the cellularity. A biopsy is a better indicator of the cellularity than the aspirate. A child's marrow is this cellular, about 80 to 90%. In an adult, it's about ranges from about 30 to 70%. And elderly patients have a slightly less cellular marrow. That's normal. This is again an important observation that we do. This presence of fat at the paratrabecular region is normal. This is called the first fat space. And obliteration of this space happens in hypercellular marrows. Look at this is slightly hypercellular, and the fat spaces are getting obliterated. And this is a totally packed marrow. There is no first fat space available. So observing this fat space can give you an assessment of the cellularity. We also have a problem with Trephine biopsies is that the subcortical area, about 2 marrow spaces, are physiologically hypocellular. So if you have a small biopsy, you often may mistakenly call it hypocellular, but the actual cellularity is a few marrow spaces away. So this is one biopsy, hypocellular first space, but a very cellular beyond that. So keep that in mind when you're looking and reporting on a biopsy. So how do you evaluate? Minimum in an aspirate, a minimum 200 cell differential. I still would recommend that if you are looking at a case of an acute leuk, counting blasts, plasma cells for myeloma, blasts for MDS, lymphoma spill, go up to 500 cells. In the aspirate is useful because it tells you about the particulate, it's erythropoiesis, myelopoiesis, the cells are seen. Aspirate is a good, very, very good for morphology. Okay, so when you are assessing the morphology, aspirate is to be used. Trephine tells you about the cellularity and the overall topography and architecture. So when you are dealing with cases where you need to talk of the topography and architecture, a biopsy is needed. In addition, biopsy tells you the fibrosis, helps you in infiltrations, which are often patchy, and certain other stromal changes which are picked up on the biopsies. So this is an aspirate, a very nice cellular aspirate. But a well-stained, well-made, thin biopsy section is also equally good at morphology, though may not be absolutely at par with an aspirate, but you should not have any problem if your biopsy is there. So these are all excellent morphology can be assessed. Okay, just for a breather, did you hear what happened to the RBCs, WBCs, and platelets? All those who have heard me before, well, they all had a marrow escape, right? So let's look at some of the cells in the marrow, how they look like. Erythropoiesis, as you know, goes through a sequence of events from proerythroblast to an RBC. And this is how an aspirate looks. You know, you're all more or less familiar with the aspirate, the early, the intermediate, and the late. And that's how it looks. This is an aspirate, and this is the biopsy appearance. They're always in clusters, and you can make out the early forms and the late and intermediate late forms. One way to identify erythroid cells for those who haven't are learning process is this little cleave or little clearing around each of these cells. Okay, so that's how you identify a cluster of erythroid cells. This I will discuss again when we have to differentiate it from lymphoid cell clusters. So this is a nice low power view of the biopsy showing erythroid hyperplasia. At times, when you are looking at these cells, you are a bit worried. Are these large cells? These are blasts, definitely. Erythroblasts have this typical longitudinal shaped nucleolus, and often the nucleolus is sticking to the periphery. Okay, so at times you need to do, not at times when you have to identify whether they are erythroid or myeloid or whatever. And here comes the role of a immunohistochemistry in Trephine biopsies. The early erythroid precursors are strongly positive for E-cadherin and CD71. Okay, these are seen in early as well as in dyspoietic erythroid cells, E-cadherin positivity. As it matures, the E-cadherin positivity goes down, but CD71 remains high. And as it matures fully, it's glycophorin that take over. Now, glycophorin is used very commonly for our flow cytometric assessment of erythroid lineage, but in a biopsy, glycophorin is not very useful because it stains not just the late normoblasts, it also stains all the RBCs. So the hemorrhage in the biopsy it obscures it. And it is not very good to pick up the earlier forms. So generally what we do in practice is for erythroid lineage, we use E-cadherin or CD71, but E-cadherin we have been consistently using it to very good result. The myelopoiesis takes place in the paratrabecular region. So in the paratrabecular area, you're going to find a few blasts. In a routine normal aspirate, normal biopsy, you don't get too many blasts to look at. Okay, they are not very visible, obviously. But the maturation takes place from the paratrabecular to the interstitium. Notice the mononuclear cells becoming more myelocyte-like, and you have neutrophils. And this is an area of the interstitium rich with neutrophils. So that's how they mature. And if you have a doubt or if you want to check it out, this is what we do. We can do a myeloperoxidase stain and highlight the myeloid nature of the blasts. The darker staining ones are the more mature. The lighter staining ones are the more immature myeloid cells. Again, like erythroid, at times we need to have assessment of the very immature looking cells. So for these clusters, for myeloid, we put a CD34. And that helps us highlight the abnormal localization of immature precursors. So for myelopoiesis, two good immunohistochemical markers, CD34 and NPO. The megakaryocytes, the largest cell, they are obviously visible. They have this granular cytoplasm from which platelets are budding out. And this is a Trephine biopsy, and you see megakaryocytes of different shapes and sizes. This difference shapes and sizes, this polymorphism is normal. Okay, so because megakaryocyte is such a large cell, it depends on the section at which it has got cut. So megakaryocyte, which is showing this kind of a disparate morphology, is actually normal megakaryopoiesis. This one, if you see in isolation, you might be tempted to call it as a micromegakaryocyte. But don't do that when you are seeing the spectrum of megakaryocytes. If this is the bulk of the morphology of megakaryocytes, then it is abnormal. Okay. If all your megakaryocytes are like this or like this, then it's abnormality. Otherwise, this heterogeneity is what we want. Beautifully, emperipoiesis in an aspirate, emperipoiesis in a biopsy. This is endomitosis, which probably only biopsies would show. Apart from the morphology, we look at the location of the megakaryocytes. They're usually scattered next to a sinusoid. So that's how they're usually placed. They're scattered. And this clustering is abnormal, especially paratrabecular cluster. That's an abnormality. Their morphology also can be very abnormal. These are all very large, hyperchromatic, obviously what you see in myeloproliferative neoplasm. So observe the megakaryocytes for their morphology and their location and distribution. These are definitely abnormal megakaryocytes, micromegakaryocytes, monolobe megakaryocytes, dwarf megakaryocytes. And notice this field, all the megakaryocytes are abnormal. So then this is abnormal. This is a dyspoetic megakaryocytes. For megakaryocytes, 61 anti-von Willebrand factors are useful. 61 is what we commonly use. This is one case of AMLM7 rich in 61. The other cells, plasma cells, up to 5%. Again, beautifully picked up on biopsies. If you can identify them. There's a nice, on an aspirate, we got a diluted aspirate, a beautiful sinus or a little blood vessels separated, surrounded by plasma cells all around. That's where they normally are present. And that same thing in an aspirate, in a biopsy, notice the sinus and the plasma cells around it. In case you want to highlight, you can highlight it with CD138. We prefer CD138. 38 also works. 138 is a good marker for identifying them. The reactive forms are best seen in an aspirate, the flame cells, the binucleation, the Russell bodies, but the biopsies also can show you Russell bodies if you examine carefully. That's a Dutcher body. On an aspirate, a biopsy shows a Dutcher body. So all these reactive forms can be well appreciated in aspirate and as well as in the biopsy. When you look at lymphocytes, again, as I said, you need to differentiate a lymphocyte from an erythroid. Those who are beginning in that appreciation of marrows, you need to differentiate. So that's a lymphocyte, that's an erythroid cell. Normally about 15 to 25% lymphocytes are there, more in infants and in elderly. Usually they are scattered, but at times they may be clustered. Nodule can be formed, a germinal center may be there. At that time, you need to differentiate it from a lymphoma. Another little thing about lymphocytes are to differentiate them from late normoblasts or erythroid clusters. As I said before, the clearing around the erythroid cells gives it, this is an erythroid cluster, that's a lymphocyte cluster. And if you have a doubt, it's kind of an ill-defined cluster, with margins are not very well defined. Can do a CD20 and CD3 to tell whether it's reactive or a neoplastic. So we'll come to that in a while. Macrophages are better seen in an aspirate. Unless they are florid in a biopsy, you tend to miss out on macrophages. Pearl stain is useful in an aspirate. You know that it's a Prussian blue reaction. At least 7 particles are needed before calling it grade 0. 0 is deficient, 1 is reduced, 2 to 3 normal, 4 to 6 increased. And that's how we look at pearl stain and we grade them. On an aspirate, ring sideroblasts are easier to pick up. I mean, they can be picked up only on aspirates. So in a Trephine biopsy, we generally don't do a pearl stain. It gets leached. It gets leached and an unquantifiable amount gets leached. So we really do not find it very difficult to grade iron stores on the Trephine. In case anyone is interested or doing a research on the iron stores in Trephine biopsy, I would advise a Zenker's fixative to be used. Fibrosis is again important in a Trephine biopsy, and we follow the TL 2008, or the European network classification, using 2 stains, reticulin and collagen, mesentrichrome. Grade 0 is normal, very scattered linear reticulin fibers. This is grade 1. Grade 2 when they are dense. And at this point of time, when you have grade 2, you please do a stain for collagen to identify whether there is collagenization of the marrow. And this is the grade 3B or 4 earlier when there is osteosclerosis. Currently, it's up to grade 3 collagenization, often with osteosclerosis. Okay, so there's this girl who told her mother is a pathologist. She comes back from work and the baby says, "Mama, what did you do at work today?" The mama says, "Oh, sweetie, Mama looked at slides all day." "Oh, Mama, did you look at swings too?" Right? So let's see some cases and help us swing by with the diagnosis. So this is our case number 2. It's chronic kidney disease patient, a 60-year-old retired bank officer on regular hemolysis with refractory anemia. He's on erythropoietin, but hemoglobin has not picked up. And if you look at his counts, hemoglobin is low with a reticulocytopenia. TLC and platelets are on the lower side and a normochromic index. So this is the bone marrow aspirate that we got. Myeloid cells are present. And here and there are these large erythroid cells or proerythroblasts, deep blue cytoplasm, large cells. And you notice that there are no other erythroid cells. So you have a diagnosis in hand, right? You have these cells, large cells. You know that you're dealing with something like a pure red cell aplasia. The biopsy helps you just to corroborate. You have these erythroid precursors, the proerythroblasts. If you want, you could highlight them with E-cadherin, and you have a diagnosis of PRCA. Now, I'm not going to the details of all the theoretical aspects, but in a patient with kidney disease, most of the time this red cell aplasia is because of antibodies to erythropoietin. However, they may also be prone to parvovirus P19 infections. What else did the biopsy show us? This biopsy showed us this paratrabecular fibrosis, scalloping with osteoclasts and osteoblasts, paratrabecular fibrosis, collagenization, and this kind of a feature is what is seen in renal osteodystrophy. So this is probably one of the reasons why his, apart from the erythroid suppression, because the marrow architecture was also getting damaged, getting fibrosed, his hematological response wasn't very good. So in bone marrow biopsies in isolated anemia, let's talk of this at this point, and I'll discuss it again later. If your RBC is anemia and it's microcytic, there is no role of a bone marrow unless you're suspecting a rare MDS with microcytosis. If it's a macrocytic index, we are all aware that bone marrow is not done for the diagnosis of megaloblastic anemia anymore. With the availability of B12 folate levels, or even if it is, if you do just therapy can be started, and response to assessment is a good surrogate marker. So when do you do a bone marrow biopsy when you have a macrocytic index, unless you're suspecting MDS, refractory to treatment, associated with other organomegaly or other cytopenias? Or there are red cell morphology, which tells you that the marrow is also involved. So in such situations, yes, bone marrow and aspiration and biopsy. Aspiration alone is enough in certain conditions, I feel, on PRCA, CDA, sideroblastic, unless you want to do something like an electron microscopy, etc., to diagnose. Let's look at the third case, a 44-year-old man with pancytopenia. Again, the indication is pancytopenia, floridly hypocellular marrow, few mast cells here and there, plasma cells here and there. The one focus is hypocellular. Okay, this is aplastic anemia. The entire marrow is hypocellular and aplastic anemia. So you can diagnose that on a Trephine biopsy. Mind you, in an aplastic anemia, often you get good particles. So it is not really a dry tap. You get hypocellular fat-rich particles in an aplastic anemia. This was a 46-year-old male, farmer by profession, again had significant weight loss and fatigability. He had a past history of jaundice some years ago. He also has just severe pallor, no organomegaly, and he had pancytopenia, 3.4, 2,900, 75,000. His retic was 3.2%, unlike the previous case, and he had good number of polymorphs in his DLC. Hypocellular aspirate, but there were erythroid colonies. Lots of erythropoiesis, erythroid cells were there. Iron store was grade 0. A hypocellular fragment, but there were areas with fairly normal cellularity for his age and a kind of a patchy cellularity. So in such situations of hypocellular or hypoplastic marrows, anemias, at the age of 40, you need to do something else. And what is this? That's urine sediment being diagnosed, being tested for iron or hemosiderin. And this is a case of PNH that you can pick up. So keep in mind, all hypocellular marrows are not aplastic anemias. Okay. A 12-year-old boy had high-grade fever for 1 week with cervical lymphadenopathy and hepatosplenomegaly, no significant family history. Child was born out of a third-degree consanguinity and has a younger sibling, 3-month-old girl. The child had certain syndromic manifestations, caffeole spots and triphalangeal thumb. 4 years ago, when the child was 8 years, he had presented to us with a low hemoglobin, pancytopenic features, retic very low. The peripheral smear showed pancytopenia with lymphocytic preponderance, no atypical cell seen. The aspirate was hypocellular, suppressed tri-lineage hematopoiesis, no dyspoiesis seen. This was the marrow. And we diagnosed him as Fanconi anemia. The chromosomal breaks were identified, and he was a follow-up case of Fanconi. Current PS was also pancytopenic. There was no atypical cells in the PS. Marrow was hypocellular. In this case, we had, because 12-year-old, we did a biopsy. The biopsy at times, now here the biopsy was useful. You saw these clusters of immature cells with dyspoetic megakaryocytes. And so you apply a CD34 and you diagnose a case of hypoplastic AML in a background of Fanconi anemia. So that's where the biopsy scored in this particular child. So when you have an hypoplastic or an aplastic marrow, one, the severity and the cause has to be determined. Up to 40 years, please rule out a constitutional anemia, constitutional Fanconi or dyskeratosis congenita. Beyond 40 years, it's good to rule out PNH. And when you are examining the marrow, please rule out a hypoplastic MDS and AML. Another pancytopenic patient, 80-year-old, pancytopenia counts are all low, and the peripheral blood shows this abnormality. That's a pseudopelgar anomaly. It's very cellular marrow. In the aspirate, we saw almost megaloblastic erythropoiesis, right? Very much dyserythropoiesis was there. The imprint wasn't a very good, the aspirate wasn't very cellular, but we identified blasts, myeloblasts, but they were not reaching up to 20%. Iron was raised, and on close look, we found ring sideroblasts. So we know we are dealing with an MDS. Right. The Trephine biopsy was useful. Again, showed these clusters of immature cells, some obviously erythroid, high atypical mitosis. E-cadherin was positive, as was CD34. Not really up to 20% again, but CD34 positive blasts were there in the interstitium. H&E also revealed very dyspoetic megakaryocytes. CD61 highlighted that. So we had this pancytopenia, elderly male, typical features of MDS, right? Dyspoiesis in more than 10%, ring sideroblasts, blasts less than 20%. Cytogenetics done, showed gains of hyperdiploidy, and we would diagnose this patient as an MDS EB2 with ring sideroblasts. In MDS, morphological features of dyspoiesis are better seen in an aspirate and imprint, whereas the architectural and topographic disorganization is seen in a Trephine. So this is one situation where both act very complementary to each other. Our seventh case is a 58-year-old lady presented with easy fatigability, giddiness. She had been diagnosed for the last 2 years as anemia, has been on hematinics, again refractory. Her issue was low counts, low hemoglobin, low TLC, but platelets were high. MCV was macrocytic. She had a few features of, the Hubble-Jolly bodies and Cabo rings, etc., on the peripheral blood, but somehow didn't fit into the features of her B12 folate levels were normal. Aspirate done, gave us the diagnosis. You saw this here again, the megakaryocytes. Look at the megakaryocytes, they're all small, monolobed megakaryocytes. So there was increase in megakaryopoiesis with monolobed forms, bilobe forms, lobe separation. And this was the Trephine, a very cellular marrow for her age. And there were clusters of these monolobed megakaryocytes. Okay, CD61 highlighted that. So we were able to diagnose 5q minus syndrome, and cytogenetics definitely helped. Another situation where Trephine often coordinated or helped was a 3-year-old child with Down's phenotype. Platelets was high again, TLC was low, hemoglobin 7, and this child showed presence of blasts in the peripheral blood itself, and the blasts had a very heterogeneous appearance. Some resembling myeloblasts, some, of course, with blebs resembling megakaryoblast. The aspirate was more clotted than really hypercellular, and so we had a difficulty in doing a good assessment. And it was clotted because there were clumps and clumps of platelets. You see these megakaryocyte fragments, blasts in it, but we were not able to give a good count or a good differential was not possible because of this clustering of the cells. CD34 we did as an immunocytochemistry, both 34 and 61 highlighted these cells. The Trephine biopsy helped, and there were these bizarre megakaryocytes all over proliferating. CD34 was strongly positive, CD61 was strongly positive. Very dyspoetic megakaryocytes were seen here and there, and CD61 was like this. You notice the mature megakaryocytes as well as these mononuclear megakaryocytes all taking up CD61. So we were able to diagnose. Karyotyping revealed not just a trisomy 21, also a trisomy of 8. So acute megakaryoblast leukemia in a case of Brown syndrome. So this was another case of an acute leukemia. Presentation was very severe bone pain and severe pancytopenia. Peripheral blood showed leukoerythroblastic picture. Blasts were myeloblasts or lymphoblasts were not seen very clearly. And the bone marrow was totally degenerated. And this was why the bone marrow was degenerated. The biopsy was necrotic. It was necrotic, but there were these focus of blasts. Flow was inconclusive as blasts were not there in the flow of material. And this is how the cells look. It looked like, the typical coagulative necrosis that we see, tombstone that we teach our undergraduate students. It was CD10 and TDT positive. So it was an acute B lymphoblastic leukemia with extensive myelonecrosis. Post-chemotherapy is another situation where biopsies are important. The diagnostic difficulty is accentuated in conditions of regenerating marrow following chemotherapy, where the erythroid precursors may resemble the residual leukemic blasts as well as the regenerating immature myeloid cells. So when you're dealing with post-therapy marrows, of course, nothing to take away from MRD assessment. That is the gold standard that is done. But a biopsy may help. In this case of ALL, day 28 marrow. What are these cells? TDT, negative. CD34, negative. E-cadherin, positive. So you know you're dealing with a regenerating hypocellular marrow. This is a case of AML, day 28 marrow. It's again pretty cellular. You see the erythroid cells, but what are these cells? Are erythroid or what are they? Regenerating myeloid cells? E-cadherin is negative in those, and CD34 is positive. So now you know that this patient has not responded. His response is not good. So in acute leukemias, what is the necessity of a bone marrow biopsy? Generally not. Generally, you can do away with a biopsy. Yes, aspirate, peripheral blood, immunophenotyping, and aspirate is good enough. However, in certain situations, a Trephine biopsy may help. Subleukemic leukemias or a hypercellular acute leuke. When your acute leukemia is associated with fibrosis, with necrosis, with myelodysplasia, and your follow-up monitoring when you're doing the check marrows. The 10th case, 70-year-old male with a big spleen, pancytopenia, lymphocytic preponderance, and situation where your aspirate will not help because they're often diluted, and you get these, the biopsy is typical, the chicken wire appearance, highlighted with reticulin, CD20 positive, and you can do the entire panel. Bone marrow biopsy is useful in some other types of lymphoma leukemia, especially the splenic lymphomas, hepatosplenic T-cell lymphomas, where the Trephine biopsy is often of use because of its pattern. We just go to that. A 45-year male who had a cervical lymph node came for FNAC, and because he also had a high TLC and platelet, peripheral smear that was done during the time of FNAC showed lymphocytes, atypical lymphocytes with cleaved. They were typical follicular lymphoma pattern. He was diagnosed with a follicular lymphoma. And the Trephine biopsy, the aspirate did tell us that the lymphocytes were there, but the Trephine biopsy was useful because of its typical paratrabecular architecture. So that's again another way by which a Trephine biopsy helps. This was an 8-year-old male, and I must thank Dr. Rajiv, my student, who gave me this case. He had a past history of prostatic cancer 2 years back, had prostatectomy followed by chemotherapy, presented now with pancytopenia and splenomegaly. Again, notice pancytopenia. And this was the Trephine biopsy. On closer look, on a very superficial look, it looks like an okay marrow. 8-year-old man, slightly hypercellular. Okay, anyone can spot here? You see the myeloid cells, you see the erythroid cells, you see the megakaryocytes. And on closer look, now start looking, and you see these cells inside sinuses. The sinuses are dilated, and you see them. I'll just show them here. Atypical lymphoid cells in sinuses. Another one. What do? You do your markers, CD34, highlighting the sinuses, CD20. All those cells are lymphoid cells, CD20 positive, and you come up with a diagnosis of intravascular B-cell lymphoma. This is one. It used to be my favorite bone marrow biopsies, Hodgkin lymphoma for staging. We have got a series of cases where we have diagnosed Hodgkin's lymphoma primarily on the Trephine biopsy, because all these patients presented with abdominal or mediastinal nodes. And most of them were nodulous sclerosis Hodgkin's. So this is one. In Hodgkin's lymphoma, what happens, your aspirate may be absolutely normal because it has a very typical patchy appearance. This side, if you aspirate from here, you are getting a normal marrow. But this entire other half of the trabecula is infiltrated. And when you look closely, you are going to find Reed-Sternberg cells. Do your CD30 and get it done. But currently, with the advent of PET scan, the need for doing a Trephine biopsy for Hodgkin lymphoma and some other lymphomas has gone down. So it's a useful technique for staging of some lymphomas, not all. Our study has shown that 16% of Hodgkin's, we have published it also, including stage 1 and ALPHL, did show marrow involvement, but the current guidelines say that PET-CT only for high-grade stage 3 or 4, or when it is suspicious on PET, you need to do a biopsy. Amongst NHL, almost all types show marrow involvement with variable frequency. Follicular, Burkitt, T-cell lymphomas is where, again, a Trephine biopsy is useful. We are getting quite a few cases of T-cell lymphomas with marrow involvement. And the pattern of infiltration gives you a clue, especially if the bone marrow is the primary site of your detection of lymphomas. There you need to do the primary, and you can do the IHC and come to a reasonable diagnosis. Now, another contentious areas, 58-year-old man with bleeding. 15 woman with bleeding. Bleeding comes for 2 days, postmenopausal 5 days. She was apparently well, excepting for hypothyroidism, on certain hormone therapy for the last 10 years, thyroxine therapy. Okay, her problem was this very severe thrombocytopenia, extremely severe thrombocytopenia, and she was literally bleeding. To do a marrow or not, whether to do or not is that question, that comes up always. Whether we are dealing with, when we do a marrow in thrombocytopenia, we're looking necessarily at the megakaryocytes. Now, a classic young person with acute onset bleed, and you know that you're doing an ITP, there is probably no role of a bone marrow. But in this situation, because she was elderly, or if she has spleen, or the patient has other cytopenias, or atypical cells in the peripheral blood, not responding to the initial therapy, not prior to starting steroid therapy, some guidelines say that, or prior to doing a splenectomy for ITP, you need to do a marrow. And the marrow generally shows megakaryocytic hyperplasia, clustering, immature forms, right? In this particular case, the aspirate was like this. Very cellular aspirate, good number of erythroid and myeloid cells, kept looking, we did not find megakaryocytes. The Trephine biopsy also aided. There were hardly any megakaryocytes. CD61 was practically zero. So we came up with a diagnosis of a megakaryocytic thrombocytopenia. Okay, so these are among the rare cases where a Trephine biopsy would be of use to her. Also, another point that I'm often asked, is there a cutoff for platelets? No. Low platelet is usually not a contraindication for marrow. You just need to apply pressure, observe the patient after the procedure, keep platelet around if you want. But remember that if it's a functional disorder, thrombocytopenia with functional disorder or secondary to a coagulopathy, please do not touch the patient for a bone marrow. Okay, so these are the two things that you must remember. This particular patient, 3,000 platelets, we were able to go through it. The next case, a 14-year-old man, again, diabetic patient who presented with gangrene of the lower limb, awaiting amputation, and had a massive platelet count of 17 lakhs. Okay, and it was sustained for about 3 months. The peripheral blood was full of platelets. And this was his aspirate, cellular aspirate, but very bizarre, very large megakaryocytes, hypersegmented megakaryocytes, mild loose clustering of megakaryocytes, and a diagnosis of essential thrombocythemia was made. You work up a patient for MPN, do the other molecular, and you get a diagnosis. So marrow is usually normocellular with not much of a significant granulocytic or erythroid proliferation and uniformly large megakaryocytes. So in the WHO classification or guidelines, bone marrow biopsy is an important component of the diagnostic features of ET and other non-CML myeloproliferative disorders. Similarly, a pancytopenia with massive spleen, notice the tear dropping, notice the leukoerythroblastic picture, occasional blast. Aspirate is not very good. Biopsy helps you in the diagnosis. There is attempted streaming or fibrosis and these very hyperchromatic, bizarre-looking megakaryocytes. reticulin is increased, collagenization is there. And for myelofibrosis also, primary myelofibrosis, whether it's in the fibrotic stage or the overt stage or the pre-fibrotic stage, you need to do a marrow along with the other diagnostic protocols. So this is, we look at the megakaryocytes in polycythemia vera, essential thrombocytosis, and primary myelofibrosis. There are differences in the morphology, differences in the pattern, differences in their distribution. So in a myeloproliferative neoplasm, aspiration generally has no role. What about CML? CML, BCR-ABL positive, again, aspiration is not indicated. But here I'd like to tell you a little story, whether bone marrow at all is needed in CML. When I had initially my first PG dissertation that I was a guide of, it was on bone marrow in CML. And there we did find what earlier authors had also said, the bone marrow trephine biopsy of classifying it as granulocytic and granulocytic megakaryocytic did have a kind of a prognostic look. The granulocytic ones went into progressive disease or blast crisis early. The granulocytic megakaryocyte type went into myelofibrosis. Okay, so that did have a role. Then it got blurred once imatinib started, and imatinib therapy. In another subsequent few years later, another thesis that we had done, this differentiation on trephine did not work out. However, last year I finished my PhD, finished his dissertation on microenvironment and CML, and it was on a sizable number of 150 CML patients. And we did find, again, going back, and now we know that there is a lot of patients with imatinib resistance, and the progression is there. Again, we realized we done the same classification, and we did find, again, that the original classification of granulocytic and granulocytic has probably some meaning in trying to tell us about the progression of the disease. Okay, but for CML, to identify progression or fibrosis, a bone marrow may be needed. So during the period of time, it's absolutely important to do bone marrow trephines in all the Philadelphia negative MPNs. We have this 29-year-old male with, again, pancytopenia, MAHA with leukoerythroblastic blood picture. Notice again, shift to left, etc. This patient we thought had schistocytes. Okay, the peripheral smear showed a lot of schistocytes. So we took it up as a MAHA, but the patient did not really have any coagulopathy. No kidney, everything was normal. Everything was quite all right. PTA, PTT was not prolonged. FDP was negative. So in view of the leukoerythroblastic picture and severe anemia, we did a bone marrow. And there it was, metastasis. Unknown primary. This person had the entire marrow was replaced. There was a lot of osteosclerosis, new bone remodeling going on. Usicamin was positive, CK7 was positive, CK20 was negative. And we advised further. This is a young patient, but a stomach biopsy done showed adenocarcinoma. We have published this series of about 8 cases where all of them presented with features of microangiopathic hemolytic anemia and turned out to have younger patients, young age patients, turned out to have metastatic adenocarcinomas. This slide is again a very sentimental slide for me because this was the last photograph that one of my colleagues who's no more had clicked and given it to me. This was a child with pancytopenia and an orbital mass, and the bone marrow showed this round cell tumor. Elongated desmin was positive, and we reported an embryonal rhabdomyosarcoma, metastatic. So in metastatic conditions, the peripheral blood is often a clue. Pancytopenia can be seen in 10%. Breast, lung, prostate, stomach, melanomas, renal cell carcinomas, even squamous cell carcinoma of the lung we have seen going with the marrow. Trephine is useful for staging of certain childhood round cell tumors, especially neuroblastoma and embryonal rhabdomyosarcoma. And the biggest role of bone marrow trephine comes in all these carcinoma of unknown primary, where it can help you identify the primary to a large extent. What about a patient who comes with bone pain and you have this typical lytic lesions, that is, you're expecting a myeloma? Routine cases, aspirate is good enough. It will help you identify all the plasma cells, quantify them. It's all right. But myeloma can be associated with fibrosis, where the plasma cell burden is often underestimated. So that's one point where a trephine biopsy helps. Myeloma can be associated with amyloidosis. So these situations, your counting of plasma cells become slightly undermined in aspirate. So another very interesting case, just I put it as a trivia. This was a myeloma which showed erythrophagocytosis, unusual. Now, why I put this case up on a Trephine biopsy, somehow they resembled Russell bodies. Though we were convinced on the aspirate, no, these look like RBCs, but here, if you had looked at the Trephine, are they Russell bodies? So here we did a glycophorin IHC and confirmed that these were erythrophagocytosis. In lymphomas and myelomas, this pattern of bone involvement makes us want to do a Trephine. Notice this case, almost a hypercellular marrow. This is a case of myeloma. This area is showing the infiltration. That can be very interstitially present, and you're needing an IHC to document the presence of plasma cells. There can be nodular presence with lambda. This is positive. And then, therefore, comes the situation of IHC in bone marrow biopsy. This was my thesis slide. We had identified long ago when I was doing my thesis under Tejinder Singh. We had done immunohistochemistry. It was at the infancy in our country then, but we did it. EMA was what we had done, only one antigen, and that was positive. So it is useful in metastatic for unknown primary, in Hodgkin and non-Hodgkin lymphoma for staging, hypocellular marrow CD34, myeloma you can use for diagnosis, especially in the ones which are not florid involvement. It can highlight hidden cells like the case of BRCA. It is useful in acute leukemias when your material for flow is inadequate. Some other conditions, just a couple of cases where bone marrow has helped. 30-year male with HIV positive, fever on and off. So you're doing it for PUO. And there is definite cytopenias. And you get granulomas, AFS positive. HIV patients, generally, if you do a AFS, you will find them as positive. In a more florid presentation of atypical mycobacteriosis, the bone marrow Trephine biopsy with florid AFB positivity. So in PUO, it's a useful indicator. You can pick up one of our cases where we saw cryptococcus in the marrow. A 40-year-old lady, again, a patient of HIV positive with severe pancytopenia. The aspirates were very paucicellular, but notice that all around each particle, there was this eosinophilic material, and that was Alcian blue positive. This was the Trephine biopsy showing a case of gelatinous transformation. Unusual findings, but we are getting cases. These are usually seen post-chemotherapy. We've also published cases with HIV and marrow involvement. So basically, many causes, classically described in starvation and anorexia nervosa, but we find it in mostly in post-therapy marrows. 23-year male with jaundice, who's a laborer from Orissa, presented with fever. Clinical impression was malaria and leptospirosis, but had, again, pancytopenia with very much elevated liver. The liver showed, this was the peripheral blood. We identified sickle disease, sickle cell. The patient subsequently died. And the marrow and the liver biopsy came. The marrow was totally necrotic, but the vessels were choked with sickled RBCs. Similarly, the liver had lots of sinusoidal congestion with sickle RBCs. So myelonecrosis is another thing where a Trephine biopsy helps. The last case, a 3-month-old child with massive splenomegaly, hepatosplenomegaly, considered for storage disease. Aspirate was dry. This showed a cellular marrow, but the bone marrow trabeculae had this very abnormal kind of calcification. Mineralization was extremely haywire. Lot of osteoblastic and loss of osteoclastic activity. You get an X-ray done and you diagnose osteopetrosis. Right? In a storage disorders, a Trephine biopsy has not helped us out anyway. So the stroma-rich paucicellular marrows, fibrosis, osteosclerosis, necrosis, serous atrophy, and amyloidosis. Trephine biopsy helps. What happened to that case one that I had started my whole talk about with the dry tap? It was a metastatic carcinoma, prostate-specific antigen positive, primary presentation in the marrow, and we diagnosed prostatic cancer metastatic. This is an important whatever observation that we have got. On the left-hand panel are those cases where aspirate alone has helped in almost all the cases. Acute leukemia, diagnostic. Hypersplenism, we do get a lot of cases with portal hypertension. ITP, megaloblastic anemia when we used to do it. Hemophagocytic lymphohistiocytosis, storage disorder. In all cases, the aspirate has sufficient to be diagnostic. The bone marrow biopsies were more useful in Hodgkin's when it was done routinely. Almost, I have not yet seen a case of aspirate where a Reed-Sternberg cell I have diagnosed. NHL, in about 30% cases, the bone marrow biopsy proved superior. PUOs, myeloproliferative neoplasms, MDS. In aplastic metastasis and post-therapy marrows, there was a complementary role of both aspirate and biopsy. Is it everything very smooth and easy with Trephines? No. First and foremost is this delay in reporting that the clinicians are always after us. Aspirates must be reported within 24 hours, even earlier if possible. As early as possible, it's possible to report on, give a basic report out. The problem with Trephine is this decalcification that takes time. Some of the good decalcifiers take a lot of time. So this turnaround time that we use versus morphology is always a game that we have to play. And Hammersmith protocol has proved to be good for us. I'm sure if other centers also who are doing it find it easier. What are the other problems? This is what is a common problem, hemorrhagic biopsy. Especially I have noticed when an aspirate is done before a biopsy, this hemorrhage occurs. And that really turns you off and you cannot give a good diagnosis. Or adequate length. This particular case has nice granulomas. But if the biopsy was inadequate, if you had just taken from this portion and given a 0.2 centimeter or a 0.3 centimeter biopsy, the diagnosis would have been missed. Or this patchy distribution, osteosclerosis, if your aspirate or if your biopsy is small, you might tend to call it a normal biopsy where the bulk of the lesion is separate. So this is why we need a good, at least a 2 centimeter is a good length for the biopsy. And always for a pathologist, I would like this, that whenever you are giving a report out on an aspirate, please put this word, when you think that the biopsy is going to help you out further, kindly await Trephine biopsy or a report on Trephine will follow. Don't write this for all reports, but be sure that you intimate your clinician, inform your clinician that there is something else that we might pick up. So please wait for a day or two before we do the Trephine biopsies. So in our situation, unsatisfactory biopsies have been seen in about 5 to 6%. Most of them do with the size. At times we get tangential biopsies. Along the iliac crest, if you go, only thing that we get is the cartilage. Cartilage cap, especially in pediatrics, and the other is procedural. We crush it. As I said before in my first slide, when you have to push out the biopsy from the needle, please do it from the proximal to distal. Okay, from the tip to the other backward. Don't force it out of the tip of the needle. Hemorrhage and fractures are common. So I would advise you not to hold the biopsy during processing further with forceps. Don't crush. Use your fingers for transferring the biopsy from wherever you want to do. Other problem that we face is over or under decalcification. So these are some of the things: inadequate length along the bony crest, or such a nice long piece but entirely cartilage. So these are some of the pitfalls that we have. All your various procedure-related problems, crushing, hemorrhage, etc., fracture, etc. So the last points: aspiration or biopsy or both or none. Mind you, they are complementary. And there is a whole lot of investigations beyond an aspirate or a biopsy. Bone marrow may not be done at all. Now, this is contentious. I think there will be some agreement or disagreement. We may not do a bone marrow when we are suspecting megaloblastic, when we are suspecting ITP, when we are suspecting CML. Aspiration may well be performed alone in those cases of isolated anemia, BRCA, CDA, hypersplenism, storage disorders, and even acute leukemias. Biopsy is particularly useful when we are investigating a dry tap, suspected hypoplastic anemias, myeloproliferative neoplasms other than CML, lymphomas, metastasis, PUOs, etc. And both definitely are needed when you are dealing with a pancytopenia and suspected MDS. So this is, again, just a repeat of what I have discussed. Amongst the cases that we did: unexplained pancytopenia, MDS, leukoerythroblastic blood picture, non-CML MPN, hairy cell leukemia, PUO, myeloma and related entities sometimes, lymphomas when it is of inaccessible sites and staging, and acute leukemias when they present with cytopenias and during follow-up. So this talk of mine I dedicate to my professors, Dr. Shashi Prakash, Dr. Sudharani, she's no more, Dr. Tejinder Singh and Dr. Shom were the pioneers who built up my knowledge of hematology and Trephine biopsy, and every other faculty member when I was training in MAMC for being the wind beneath my wings. Also, a note to all of you that we are doing a hands-on workshop at Mahatma Gandhi Medical College, end of this month, 28-29, on morphology, the cornerstone. There will be all these cases that I have shown will be there, along with peripheral blood and aspirates. In case you want to know the details, my email ID is available. And it's time now, I think, time to watch the match, right? All of you must be desperate. 2 o'clock, we meet at the television. Thank you, and I'll stop sharing.
Thank you. Wonderful presentation. Enjoyed listening to you, even as a clinical hematologist. We will go on with some questions. One from the audience. Probably a relatively simple question. Dr. Shilpa Saxena is asking. It's moved, okay. How do you define adequacy and do the quantitation of megakaryocytes in bone marrow aspirate?
Bone marrow aspirates, as you know, the megakaryocytes tend to be present around the clusters, around the particles. Generally, out of the trails, you'll find them around the particles. There is no strict criteria about megakaryocytes as such, but if you see 1 to 2 megakaryocytes per high power field, or over 4 to 5, that's good enough to call it. For megakaryocytes, a Trephine biopsy is useful. About 4 to 5 megakaryocytes should be there in one particle, one intertrabecular space. But it's kind of subjective still, but you do know that megakaryocytes tend to stick to the particles, often are difficult to aspirate out. So if you see a good number around the particle, 3 to 4 sticking together, that's good enough.
Thank you. Dr. Mayat wants to know, how could we differentiate ITP from MDS in an elderly person who has dysmegakaryocytosis? Monolobated, hypolobated makes about 30%.
Yeah, in ITP specifically, we don't get monolobe megakaryocytes. If at all we have to get, let's look at the morphology and the other things first. In ITP, the megakaryocytic hyperplasia is usually of immature megakaryocytes, which are larger cells with basophilic cytoplasm, and they have less amount of cytoplasm. Okay, or they are in loose clusters. So that's one. The megakaryocyte morphology is different in ITP versus MDS. Secondly, in MDS, as per the definition, we do have dyspoiesis of the other cell lineages. You have erythroid dysplasia, you'll have myelodysplasia, and other things. So, and another thing, ITP in an elderly is relatively uncommon. So, it's basically choosing between the two. But morphology of the megakaryocytes and the associated other dyspoiesis would give you a clue to whether it's ITP or it's an MDS. Uncommonly, yes, you might get single lineage MDS of megakaryocytosis. There you have to take a call, yes. Then, of course, cytogenetics and other things are there for you to work on.
Thank you. Dr. Karthik wants to know, what is your view on doing bone marrow biopsy in CML? Does fibrosis in the biopsy affect the prognosis?
Yes, that's what I said. At diagnosis, that's what I said. Initially, we used to do the Trephine biopsy between and diagnosing it as that granulocytic type, which has less fibrosis, versus granulocytic megakaryocytic type, which has megakaryocytic abnormalities and increased fibrosis. It doesn't really, I mean, it helped initially when there was imatinib, etc., were not available, TKI therapy. Currently, we have going back into it, but I'm not very sure whether at diagnosis it still would be a very useful marker between fibrosis and that. Agreed. In CML, bone marrow is needed to identify two things: fibrosis and increase in clusters of blasts, which are not apparent on the peripheral smear as yet. But this is contentious. I mean, I would, because I have done all my life work on CML, I would still like to do a CML, a Trephine in a CML, but logistics probably doesn't apply it right now.
Thank you. Dr. Ifat wants to know how to infiltrate the bone marrow with xylocaine if the person is extremely obese and your needle does not reach the periosteum.
Oh, yeah. Maybe you'll have to ask your surgeon or an anesthetist along to help you out, because it's very, very important that you give good anesthesia. So it's important to be able to anesthetize. You could use a longer needle and anesthetize, or I would suggest, if you're really concerned, you call someone else to help you give the local anesthesia.
Doctor,
my problem with obese patient has been only once in my life. I have done so many marrows. The needle got stuck. Needle broke and stuck, and I just could not. We had to rush the patient to the OT and pull it out. With an obese patient, I have faced that problem.
Sometimes the handle comes out and the needle remains.
Yeah, remains. Yes, sir.
Dr. Saundarya Ravi, what is the role of bilateral Trephine biopsies?
Well, once upon a time, yes, for lymphomas, Hodgkin's and all we used to do. But now with PET available, I don't think bilateral. I have never really experienced doing bilateral bone marrow biopsies all my life. Certain instances like myeloma, those were the days, Saundarya, when probably we didn't have too many other investigations to help us by uh, imaging, etc. So that time it used to be done. I don't have much experience. I have never really done too many bilateral bone marrows throughout the career. So I'm not very sure how useful it is. If someone else has any idea, sir, that would be useful.
We used to do it for Hodgkin staging before
Yes, sir.
PET scan.
Yes, sir.
After
Yes, sir.
PET scan, even a single site is gone.
Yes, sir. That's what.
So what are your views on the bone marrow biopsy in Hodgkin in a patient whose PET is negative by Dr. Karthik?
PET negative, I'm not very sure. I don't think we need to do a Hodgkin's, need to do a Trephine if the PET is negative. Unless it's a PET is suspicious, yes, then maybe, or if the PET is maybe diffuse, it's showing a diffuse kind of a thing, maybe yes. Stage 3 and 4, it is still recommended that you do a biopsy, but I don't think so, sir. I think sir would be a better person to answer.
Right, we do not do anymore. It's just
Yes,
the
sir.
PET scan.
Yes,
Dr.
sir.
Mahadeva wants to know, it's a long question. From Goa, we outsource the samples to another lab. Bone marrow biopsy samples are transported in 10% formalin to another lab to process further, which reaches the processing lab after 16 hours, where they start decalcification. Any technical issue in getting the results in such situation, especially the IHC, because decalcification process starts almost 16 to 24 hours after doing the procedure.
I don't think there should be a problem because before we started this Hammersmith protocol, we used to follow the 10% buffered formalin only and followed by decalcification. 16 hours is a good enough time, I think, for it to remain fixed and decalcification started thereafter. Mind you, one of the few antibodies which we have faced problem with over fixation is actually CD30. CD30 somehow loses its antigenicity if you fix it for a long time in formalin. Other than that, I think 16 hours is good enough for you to just fix it in formalin and then start with decalcification. Depends on what decalcifying agent they are using, though. So that is probably more important. If they're using something like nitric acid and all for quick decalcification, that can hinder the morphology. But formic acid, acetic acid, and EDT are excellent decalcifiers, which preserves morphology and antigenicity.
Right. Dr. Jyoti Sane, in borderline plasma cells, especially after the treatment or in patients of MGRS, IHC on the plasma cell becomes a difficult and inconclusive. It becomes a troubleshooter to differentiate kappa, lambda.
Yes,
What
sir.
are your comments?
Yeah, very true. In fact, generally doing kappa lambda on a Trephine biopsy itself is a bit difficult issue. It's challenging to get a good result. And post-therapy to identify them is very difficult. So I think I would rather not go so much by the biopsy, but would do maybe a free serum light chain ratio, etc., other things to look for, or MRD assessment to look for the plasma cell load post-therapy. It is difficult. It's challenging.
And if you have a good flow lab, that can help you.
Yes, that's what I said. Good flow lab, that is a better option than trying to do IHC on a Trephine.
Dr. Kajumi Patel, borderline plasma cell in aspirate 8 to 11%. How do you exactly count the plasma cells in a borderline cases? We face difficulty in PMF and MDS with fibrosis. Counting
plasma cells in PMF. Is it needed? I mean, you don't have to be very specific about the counts in, suppose it's one of those fibrotic marrows, not myeloma. I really don't think there is any role. Yeah, Dr. Kazumi, any issues?
The question is different. First question was I want to ask, sir, sometime in plasmacytoma or some cases, we find the borderline plasma cell, 8 to 10%, and we do the Trephine cases. In case of Trephine, interstitial infiltration is seen in plasma cell, but how to differentiate the count in that cases?
Yeah, okay. It's a case of plasmacytoma, then yes, then you would be interested in knowing the actual level. As I said, aspirates are usually underestimate. So trephine biopsy, you do it, see the clustering of plasma cells, use maybe CD138 and if possible kappa lambda, and that will help you in kind of telling you how much is the plasma cell load. In a trephine biopsy, it's difficult to give an absolute value. So what we do is more than 20%, less than 20%, more than 50%. That sort of a thing you can argue upon and then decide whether it's a myeloma in a plasmacytoma or it's just a plasma cells. So counting, looking for the plasma cells, CD138 helps. If the plasma cell load is, let's say, about 12, 13, 20%, even your kappa lambda will help, will be able to isolate the thing. And or if you have a flow and trying to identify the plasma cells, you can do that.
Okay, and the second question was in case of in case of MDS and patient get a dry tap, and we face the difficulty in differentiating MDS or primary myelofibrosis because the fibrosis is grossly so much seen in that cases. These two things, and I supposed to go with a megakaryocyte morphology, but sometimes in both cases megakaryocytes are dysplastic. So how to differentiate cytogenetic and the molecular will be helpful, but on morphology, how to we can differentiate it.
Yeah, it may be difficult, I appreciate. In MDS, you would get, if there is such an extensive fibrosis, I think it's impossible to really go into the morphology of either erythroid or myeloid. I mean, I would apply if it is case by case entirely. I'm just trying to think of a case where there is so much fibrosis that I'm not able to identify, fine. But if I possible, I'll try and look for ALIP increase in which will direct me towards an MDS. I would look for the megakaryocytes if they are available. Their morphology is actually different. In a MDS, you generally tend to get smaller megakaryocytes with monolobe, whereas in a myelofibrosis, they're usually large with extreme hyperlobation, etc. But it could be difficult at times, and I think you will need to do the I mean, it's entirely case by case. I mean, so I really don't have an answer for that exactly. Depends on what are the available other cells that are available for your visualization.
Yeah, we will move on. Dr. Deepa Rani wants to know best decalcifying agent for maintaining the morphology in a biopsy.
EDTA for morphology, without a shade of doubt. EDTA is the best of the lot, though it is a very slow decalcifier. We have had very good, you have seen the photographs that I have got. They are all, some of them are pretty old cases also. I've taken the photographs recently. Formic acid is good. Formic acid has worked for us. I mean, during my thesis also, we used formic acid at that time long ago. But EDTA, they say morphologically is the best.
Dr. Meera Vardarajan, in amyloidosis, there can be coagulopathy due to factor 10 deficiency. How do you do a bone marrow trophine biopsy?
No, if there is a coagulopathy and the patient is symptomatic, I would rather not go ahead and do a bone marrow.
Yeah, so simple for clinician, do PT-INR, that is normal. Yeah. Okay. Dr. Deepa Rani again, what is the role of doing bone marrow biopsy in patients of chronic hemolytic anemia?
Chronic hemolytic anemia, unless maybe AIHA or autoimmune with CLL or something, then maybe yes. Otherwise, I don't see much role unless it's, of course, a PNH that you're trying to work up.
Right. In cold agglutinin disease, often there is a lymphoproliferative disease in the marrow underlying. So I think that's the only great indication where we keep doing bone marrow biopsies.
Yes, you might have to then.
Dr. Ifat, in a case of minor distortion in the gamma region on protein electrophoresis and bone marrow having less than 10% plasma cells, should we advise the patient to go for a follow-up bone marrow to find out the progress of the disease or just follow up with serum protein electrophoresis?
Yeah, that's again debatable. The rate of progression of MGUS or smoldering is rather slow. I think first you look for electrophoresis and the thing. If it is progressing, then yes, maybe a marrow can be done. Because yeah, I would look at it that way.
Right, and here serum free light chain assay can also help.
Yes, yes, those will help. The biochemical serology will help.
NM wants to know, does the bone marrow trophine biopsy gaze affects the Trephine biopsy, the needle gaze? Does it affect the Trephine biopsy?
Needle gauge, yes. Generally, we have a needle gauge of about 18 to 20. Thinner needles will obviously distort your morphology. Thinner, don't use I mean, that's why I generally don't advise an aspirate needle being used for a biopsy. It's better to have two separate needles. A biopsy needs a slightly thicker board needle.
Right. Dr. Deepa Rani again, how to give morphological diagnosis of PNH by bone marrow Trephine biopsy?
You cannot give a morphological diagnosis of PNH. You can only suggest. What are the points that I described in the case? There is one, the cellularity is patchy. One, PNH can be both normocellular, hypercellular, or hypocellular. It's easy to pick up the hypocellular PNH because there is this kind of a patchy cellularity. Erythropoiesis is often not so suppressed as the other myeloid and megakaryocytic series. Iron stores are depleted. So these could be your kind of the surrogate features which are there in a PNH. So what we advise is all patients more than 40 years, if you are getting a hypoplastic marrow or even an aplastic marrow, just do a urine hemosiderin. Before you can, if you have facilities for the clonal assay of whatever, 59, 57, 6, that's fine. Do a urine hemosiderin. And if you have a picture, those you follow up for PNH. It doesn't have many a times PNH can just show a normal marrow or erythroid hyperplasia in a very reactive marrow. So it's difficult to pinpoint on PNH.
Right. In a hypoplastic marrow, LDH high is a pointer to PNH, and in a PNH, hypoplastic marrow is the indication to do the biopsy.
Yes.
Dr. Kanan wants to know, no, he has a comment. In an obese person, I use LP needle to infiltrate the site and then do the biopsy.
That's what I said. A longer needle would help.
Dr. Shantanu, fresh format from last evening should have full screen option. No, that's okay. That's a comment. We now go to our discussants here. Dr. Amrita Saraf.
Yeah, good afternoon, everyone, and thank you, sir. It was a beautiful lecture, Dr. Basu, and very informative cases. So I have two comments to make and two questions to ask you. So one is this, like, as you said, you often face difficulty in interpreting kappa and lambda light chains on the bone marrow biopsy. So we also used to have this, but now since we have shifted to ISH, the in situ hybridization technique, we are having beautiful results of kappa and lambda staining on the bone marrow biopsies. So even though it is a little expensive, but when we are not able to get an answer from our comprehensive myeloma panel or by flow cytometry, which many a times may not be representative, ISH really helps in terms of taking a decision whether it's clonal or reactive plasma cell proliferation in the biopsy. My second comment is like, as far as to my experience, it always helps if there are imprints along with aspirates. Because while taking out the bone marrow, you're not very sure what the morphology is going to show. So many a times taking the TAT in consideration, and clinicians are always very eager to know and they keep on calling what is in the bone marrow. So in such cases, when biopsy is taking time, many a time imprints give us a very beautiful ideas that I have come across a couple of hematologists, the clinical hematologists who don't believe in imprints. But I think more than that, I have found and I believe in that imprints should be made. And if it is better morphology on imprints, it can sometimes give additional information other than bone marrow aspirates till the Trephine biopsy sections are received.
Definitely. I mean, our protocol is do aspirate, imprint, and Trephine. All three material has to come in the same sitting. And many a times, as you say, imprint gives you information. Much better than an
So I believe like it should be done by all clinicians.
It should be done.
Sir, I have the question, like we know that ITP is a diagnosis of exclusion. Right. And many a times there is a confusion whether to go for a bone marrow biopsy or not. So my question is like, since there is severe thrombocytopenia and the cause is not very obvious, how much do you believe in the importance of IPF, the immature platelet fraction, in a suspected case of ITP when normal TLC and HB is also not that bad?
Yeah, it would be a useful indicator, I suppose. I don't really have much experience of looking at the IPF for ITP. I use it more for dengue and other recovery marrows, but I suppose it would be useful because generally, if it's a classical case of an acute young person with bleeding for a few days and you're suspecting, uh, I think rather than going in for a bone marrow and all, I think you have to make use of other non-invasive procedures. Yes.
Yes, sir.
I mean,
Sir,
it is known
another,
that the platelet volume indices, etc., are higher in ITP than in hypoplastic thrombocytopenia. That is no doubt. MPV is
yes,
often higher because they have large platelets,
yeah.
inactive platelets. Yeah.
What I will like to say about it, like we have noticed that when there is very severe thrombocytopenia, the instrument gives a flagging. So
Yes.
in that case, we cannot comment on IPF, but many a times when the IPF is high, so in those cases, definitely there was sufficient population of megakaryocytes on the biopsy. So it gives us a confidence on IPF.
Yes.
But I am
Definitely.
not saying like one cannot think of bone marrow if IPF is definitely high or they have a strong
Right.
suspicion of anything, because not all the time it's just the one lineage which is involved. There may be more than one.
Yes.
So my
Definitely.
another question
I
is,
have a comment there about ITP.
okay,
Yes, sir.
sir.
So you are right that ITP is a diagnosis of exclusion. So it can never be ruled out or diagnosed in the lab. It is the total picture of the patient
Yes, sir.
Yeah.
together with normal hemoglobin, normal WBC, normal differential, normal ESR, normal morphology of the cells. I don't think that the platelet number or IPF or the immature platelet fraction, the fluorescence, all these things really can help you in a great way, because there can be antibodies against the megakaryocytes,
Yes.
increasing the
Yes.
production. So
Yeah.
Yes.
decide about doing the bone marrow or not to do the bone marrow entirely is the clinician's decision of, is he 100% sure about ITP or there is 1% doubt.
Hmm.
If there's 1% doubt also, do it, because
We
you
should
don't
go
want to
for
make a wrong diagnosis.
Right.
So
Very
Yeah,
true.
as the age
Very true.
advances, elderly people, we are very concerned.
Oh,
definitely.
yes.
Just
Definitely.
mentioned that, there are so many conditions in elderly people which can present with thrombocytopenia.
Yes.
If you have a
Definitely.
kid of say 4 or 5 years old and all these parameters are fulfilled, then
Yeah.
irrespective of the morphology of the platelet or immature platelet fraction, you avoid the bone marrow. So
Yes.
it's a very, very sort of broad overall decision. From A to Z, you have to look at everything and then
Yeah.
decide, because you don't want to miss one acute leukemia in a child,
Yes.
miss
Right.
one
Absolutely.
DS in the elderly.
Yes.
I
No
agree, sir.
single test can help you in calling a day that don't do or do it.
Yes, sir.
Yes. Absolutely.
More of a
Absolutely.
observation that wherever like we found adequate mix, the IPF was not low until unless the platelets are coming zero. In that case, there was a flagging, and it will give a IPF of either zero or it won't give any value. So this was more of an observation, and I also fully agree with you that one should not, postpone the bone marrow examination. Sir, my another question is like, what is like application of AI and digital pathology in Trephine biopsy reporting?
Well, I did not harp on that. The part of my PhD thing was a bit on digital morphology of megakaryocytes. Also, one long ago morphometric assessment was done. I think it is going to take up. There'll be a scope for at least the morphometric assessment, and should be possible
Yes, sir. Sir,
as
another
long
comment
as
I
we.
would,
Yes, sir.
yeah.
Yes. Please carry on. Please carry on.
Sir, another comment I would like to make, like many a times we get like maximum 2 sections from, for Trephine biopsy. And then we are not very sure, then we ask for deeper sections. And
Mm-hmm.
sometimes we have noticed like when we give the report, there was no evidence of any infiltration. But then when the patient came to us to take the slide for a second opinion, there was a cluster.
Oh yes.
So
Oh
we had
yes.
to give an additional
Yes.
supplementary report. So I think that's like the preferred language is usually like what we use, that there is no evidence of infiltration by a malignancy or lymphoma in the multiple sections examined.
Yes.
It
100%.
saves us.
Yes, if you have
Yeah.
to really look at granulomas or
Yes.
infiltration, you have to take multiple sections and maybe step sections. You know,
Yes. Yes,
and
sir.
before you sign out very clearly.
So I think it's a
That-
good idea to write like multiple sections
Absolutely.
have been examined.
Provided you have taken
Yeah.
multiple sections. Yes.
Yes, yes. We do usually minimum
Yes,
3 to
definitely.
4.
Thank you,
Definitely.
Dr. Amrita. We'll
Okay,
just
thank you,
move on.
sir.
A lot of raised hands.
Yeah.
Dr. Arihant.
Thank you, sir.
Sir, thank you for the succulent talk. So, two very kind of commonly encountered situations. Uh, High count acute luke, say TLC of 1 lakh and 2 lakhs. So, do you think that an additional marrow there will help you in, say, an occasional MPAL which would be missed, or do you really think in such very high count acute lukes, the yield of cytogenetics is significantly higher as compared to say a peripheral blood cytogenetics or conventional karyotype? So, and additional role in picking up that MDS related AML, because dysplasia would be better uh, appreciated on. So high count acute luke, how important is marrow?
See, generally, marrow aspirate, I think, is to be done even if it's low count or a high count. I was talking of Trephine biopsy is not needed in certain situations. But now with earlier, when we were training, we were told that the cytogenetics and the fish and all are only possible on bone marrow material. But now it's possible on peripheral smear. And if you have a good flow, available MPAL can be picked up. I mean, there is nothing that your marrow is going to give extra. Yes, at times your MDS related changes and all can be better picked up on a marrow than just on peripheral blood. But those are a few cases only. So if you have, that again depends entirely on your lab, on your practice, and on your thing, whether you want to do a marrow in all acute leukemias or you can avoid it in very high count, good cellular peripheral blood and go ahead with it. I mean, it's difficult to really say which to do.
And sir, one more question. Elderly patients coming with cytopenias, marrow showing not that magical 10% number for the extent of dysplasia, it's say 7%, 8%. Your NGS and or cytogenetics are corroborative. Would you still label them in that ICUS chip bracket, or you are okay to call them MDS?
Yeah, if your cytogenetics is there, it matches, then yeah, why not call them MDS?
But that WHO, from what
yeah,
I understand,
I know.
still
But that
mandates
is
that
that's also
10%
that
morphology
I know.
criteria.
But that is also kind of, there's nothing specific that you can say that this is 10%. We are not doing any kind of morphometric assessment or, very objectively is 10%. It's always what you would say as 10%. I might say, no, this is 8%. This is something that used to happen when we were reporting with our seniors. You would say 12 eosinophils. The professor would say, no, there are 15 eosinophils. So it is kind of, but if you have evidence of cytogenetic thing, I think I would err in favor of labeling it as MDS. Because after all, the involvement of the marrow by blasts is patchy. You may have picked up only 8% in the core that you have got, but it could be somewhere else or slightly more. So if there is evidence that this patient has cytogenetic related myelodysplasia related cytogenetics, I would rather go in for cytogenetics.
And if I may, Agarwal sir, your take on this?
I was going to ask you, if you have a frank acute look from the peripheral blood, are you doing bone marrow even aspirates?
We are doing as a training institute, and we've a lot of cellularity, morphology, if we have to take up for transplant, etc. So where we are aiming a definitive care, we still do marrows.
Fine.
But this is a debate which we continue to do amongst our team.
So which is the test that you failed to obtain from the peripheral blood blast which you got from the marrow?
Pardon, sir?
Which is the test, say conventional karyotyping or FISH or PCR or NGS, that you failed to obtain a result from the peripheral blood blast in acute luke, which you got only from the bone marrow?
Not really. If the blasts are, say, more than 20% or 30%, I think the yield is similar. The only thing is that MDS-related AML and the T MPALs or the mixed phenotypic acute leukes, we feel that, and our hematopathologists feel that the yield may be higher in a marrow aspirate than a peripheral blood. So,
Okay.
and one last question.
Please go ahead. Go ahead.
So, MGUS, M-band less than 1.5, do you recommend a marrow or just a serial assessment with M-band protein? Your practice.
I mean, recommending a marrow is the clinician's prerogative, but
I'll just
at least a base.
Yeah.
Yes, sir. At a baseline, I suppose a marrow is needed, right?
Absolutely. Aryan, whatever may be the amount of M-band or serum-free light chain assay, there can be total discordance between the two because they have got hyposecretory, non-secretory
myeloma,
dysplasias. Then you're looking at amyloidosis, etc. So not doing a bone marrow aspiration and biopsy in a suspected plasma cell dyscrasia, however small the M-band may be, and however normal the serum-free light chain assay can be very, very dangerous. So I will never avoid doing a bone marrow aspirate and biopsy.
Very true.
For any patient who has come to a clinician. Not the epidemiological workup of all this, what is going on now, the small M-bands being picked up in general population who has got nothing else. That's a different story. But a patient has reached you means he's got something, anemia or whatever. So in that situation, if you pick up a M-band, how to avoid a bone marrow? It's impossible to avoid. What's your comment, Aryan?
So, no, that the IMWG says no, they put a star and then they say that in the low risk less than 1.5 where everything else is normal, you may avoid a marrow and closely follow up. So, and a lot of times patients who are elderly may not be very keen on getting a marrow. So that we usually recommend it most of the times, but again, sometimes we do take that individualized.
I would put it in that way. When the Mayo Clinic and etc., they talk about this, these are almost normal people. You know, come to a cardiology for some cardiac check, and there is a M-band picked up. He's got a hemoglobin of 14 grams. He's got a creatinine of 0.8. His calcium is normal. He's got nothing else anywhere. So it's almost like a population survey. That's a very different situation.
Situation from ours. Yeah, that's true. Yes, sir. Very nice.
Thank you, sir. Thank you for your
Dr. Avinash. Thank you.
Yeah. Thanks a lot, sir, for a wonderful talk. Sir, basically, I just want to ask that you said that in your study of CML, that granulocytic hyperplasia and granulocytic megakaryocytic hyperplasia, recently you found that they have a different prognosis. One is going towards the fibrosis and another is going towards the something like accelerated or something like that. So, and do we have any correlation with particular mutation? Because if we target these things earlier only, that we know that dasatinib works for particular different mutations, nilotinib works for particular different.
That's true.
So is there any correlation with ARMA studies or like
no, not right
mutations?
Now. Not right now, but all our patients were initially on imatinib. We had picked up that cohort of patients who were on imatinib and who progressed either in the form of imatinib resistance, had to be shifted to the second line TKIs. So in that group of patients at diagnosis, we have found it is not a very statistically significant, but definitely an increased tendency to progression to accelerated phase or in the granulocytic type.
So in that granulocytic phase, sir, I just wanted to know that is there any TKD mutation? Because if we know this at the time of biopsy only.
No, at that point of time, we have not done the TKD mutation at that initial point.
And sir, just one comment that many of the cases with BNH, they come with a normal aspirate and a patchy marrow.
Yes,
so people who are doing just aspirate, they usually miss this.
Yes, that's what I said.
Sometimes there is only small lymphocytic increase and scattered mast cells. And this is the only clue to go for the biopsy. Don't miss the biopsy because in 8 of the intertrabecular spaces, 2 might be the cellular and 6 might be the hypocellular one. So the length is length is very important in that. If you are missing that length and you are targeting that hot spot in that biopsy for the aspirate, then we might miss. So I'm just now came to Gwalior and I've seen 3-4 cases where the people they did just the aspirate and they missed the. So when I reviewed the aspirate, I got plasma cells, lymphocytes, and mast cells. So I asked them to repeat it. That time it is very difficult to convince the patient to do the biopsy again, and they were very reluctant. But somehow we got this, and simultaneously we sent the sample for PNH also. So many of these patients they have a very little clone. Somebody is having 5%, somebody is having 2%. So this is the thing which I learned when I came here.
Yeah, precisely. This is what I also told that. Another thing, if you have an aspirate, do an iron stain. All PNH patients would have low iron. That's another clue to PNH. And that's why we relatively say that do both together, aspirate and biopsy at the same time for as many patients as possible.
But sir, in low clone patients, the hemosideruria is not like that. So many times in this 2 to 5% clone, we are not getting that hemosideruria, and that time we have to go for that higher testing.
Yes, absolutely.
Thank you, sir.
Absolutely.
Thanks a lot for a wonderful talk. You included entire spectrum of biopsy.
So I will just one comment here. In a PNH, if as a clinician you are doing a biopsy, if you're doing a bone marrow study, it is for aplastic.
Yes, sir.
So you have to do a Trephine biopsy from the word go.
Yes,
as Dr. Basu said, why do aspirate alone anytime? So I can almost never justify in a PNH to do an aspirate. Then you're doing an aspirate for hemolytic anemia, which is absolutely not required.
No.
So you're doing it for the purpose of aplastic anemia.
Yeah.
And as I mentioned, if you've got aplastic anemia and you're looking for PNH, and if you do not have a flow, then just look at LDH.
LDH is a better mark. Yes, sir.
Yeah, LDH.
Any amount of hemolysis, LDH is up, then it is unlikely to be pure aplastic anemia. Why should LDH be high in aplastic anemia? That's a big clue for a clinically significant PNH. Yeah, I'm not talking about those 1%, 2% clone, where there will be no marker at all.
Nothing at all.
Yeah.
Thank you.
Thank you, sir.
Dr. Minu. Dr. Basu, you have some time with us, na?
I think all of us are waiting 40 minutes for the maths. That's more important than the lunch.
Maybe we'll have quick question answer. Dr. Minu.
It's okay. Please carry on.
In for fish testing, which is usually done on bone marrow aspirate, in cases of dilute marrow or when the testing is not done at diagnosis, we get a request to do it from the bone marrow biopsy. But in fish testing, we get signals only in few cases when we do it on the bone marrow biopsy, because the decalcification agents which are used, they affect the signal. So which is the best decalcification agent, and can we make a uniformity for decalcifying, though at least those biopsies in which the clinician is doing marrow and he suspect that it is dilute, so that further fish testing can be done on the biopsy?
Yeah, that is true. Fish is obviously better on an aspirate material. On a Trephine, I don't have too much experience of doing fish on a Trephine, but with whatever cases that we have sent out for fish on a Trephine, the formic acid ones have given us good result. But if you look at the literature, they say EDTA is probably a better decalcifying agent for fish. So therefore, no standardization is there. Generally, even if you look at guidelines, fish is preferred on an aspirate than on a Trephine because of decalcification.
Thank you, sir.
Thank you, Dr. Suresh.
Suresh,
thank you.
Yes,
Yeah,
hello,
yes,
sir. Dr. Suresh.
Thank you, sir. Wonderful presentation. Thank you very much. And I thank Dr. M.B. Agarwal also for this opportunity. Actually, I would like to ask one question regarding the basic techniques. So, because marrow blood is highly clotable, do you suggest to collect the marrow sample in an prior anticoagulant in a watch glass and later pick up these particles and make smears?
Generally, we do the marrow at the site. The smear is made at the site of the aspiration. That's what we have been trained, and I trained my that. Do it there and then. But in case, many times it happens that what we do is we send our pathology residents to every time a marrow is done. But if a clinician is doing not sure of making smears, EDTA, you can collect it in EDTA and send it to us as early as possible.
Yeah.
EDTA vial, send it as early
Yes,
as
yes.
possible, and we make the smears in the lab.
Okay. One more, sir. While reporting the marrows of children, especially in the diagnosis of ALL, particularly L1, sometimes we get because lymphoid predominance will be there. What about how to differentiate the hematogones from these black cells?
Well, hematogones are always a tricky issue, and you will need a good flow. I think a few things about hematogones morphologically between a hematogone and a blast is hematogones don't generally have nucleolus, and their cytoplasm is very, very scant. So, but it is a tricky thing. But on morphology, we generally try and avoid commenting. But yes, these are the 2 pointers that we keep in mind, especially a case of ALL on follow-up. Check marrows, we have to be careful about, and I think currently flow cytometry is the answer. Without that, it would be difficult to really, we have learned it that way. Morphology, we used to say, but then that was always, could be hematogones, could be blasts, but these are the 2 points when we look at a hematogone, absence of cytoplasm and absence of nucleolus in the
And also
cells.
their distribution clustering is more with hematogones.
Yeah, but in an aspirate, it's difficult to get clustering and all. Really comment on whether it's a true clustering or because of your smearing, they have come together. So,
okay, thank you, sir. Thank you very much.
Thank you, Dr. Rashmi.
Thank you so much, sir, for the wonderful talk. Sir, I have a query. Like, it has always been a problem in reporting the trephine biopsies of the elderly patients. Suppose the patient is around 70 years, presenting with pancytopenia, and the trephine section is showing any cellularity anywhere between 15 to 20% with hematopoietic islands here and there. Then what should be the final, like, should we report it as normal hemopoiesis, although knowing that the cellularity is little lower? Or should we label it as aplastic? So that has been a problem. So how to go about it?
I know that is a problem. If you look at what general dictum is, in someone less than 20%, or someone, let's say, more than 20%, if 20 years of age has an 80% cellularity, that's abnormal. Reverse is true. Above, so in an elderly, you have to really take into account, why does he have pancytopenia? If the marrow you say is normocellular, why is there pancytopenia? So if you're finding cellularity of less than 20%, 10% or so, whatever be the age, I think it is good to label it as hypoplastic.
And sir, one more question. Like in a follow-up case of multiple myeloma, while reporting the trephine section, should we quantify the number of plasma cells because it's of
as far
importance?
as possible? If your aspirate is diluted and not available, you should be able to quantify.
So
that's what I said
trephine,
in the previous thing. Thus, we said cannot say it is exactly how much, but give a range. Use kappa lambda and check it out.
So roughly like less than 20%, more than
yes,
that is only.
Why not? Yes.
Okay, sir. And one more, sir. Like, what is your experience on the use of clot sections in trephine in bone marrow aspirate?
It's very good. Whenever we have got a problem and clot has come out, it has helped us. It's pretty good.
So it's advisable to process the clot section also
if you by chance you get a clot out when you're doing the biopsy, but don't waste it. It can give you a lot of information.
Thank you.
Thank you. Akshaya?
Sir, first of all, thank you for the excellent and comprehensive talk. Sir, I have a practical query that when the samples are coming from far off places, the formalin fumes that often affect the bone marrow aspirate slides despite taking all the precautionary measures, and EDTA samples are mostly not available. Sir, if you could please suggest some strategy to troubleshoot the bone marrow aspirate staining issues caused by formalin fumes.
I would not mix them in formalin fumes. Put it in an EDTA vial and get it out. Encourage your clinicians or wherever they are doing it, whatever aspirate material has come, put it into an EDTA tube and send it. I don't think formalin fumes is a very recommended fixative for aspirates. In fact, I have not encountered or not had an idea about formalin fumes being used to send.
Sir, actually, So my exact query is bone marrow biopsy is coming in formalin, and often formalin fumes comes from, and the aspirates are coming along with that in the same package. And despite taking adequate measures to separate
Oh, you
those
mean the formalin fumes from the vial, from the
samples.
formalin vial in which your biopsy is there? Oh, I mean, ask them to pack it separately, properly, leak-proof. Those are the things, I suppose.
Is there any staining issue which we can do? Because now we have got the sample and EDTA sample is not available.
Now, why is the EDTA not sample available?
So,
They have made the smears and sent it along.
sir.
Oh,
So if I'm allowed, Akshaya, what you can do, just give them the plastic containers. Ask them to dry the slide and pack the slides in the plastic slide boxes, and along with them, they can carry it. So this is how you can prevent the formalin fumes affecting your aspirate slides. You know, small plastic container slides.
those are available.
Three or,
Okay. Yeah, that's what I said.
three
You
or
have
four
to
can
ensure.
come into that. So that will resolve a lot of issues.
Yeah. Akshay is practicing in Mumbai. I'm in Mumbai. I face the same problem. I think this is something very peculiar about these Bombay hospitals. The residents are following what exactly you said, and it's so difficult to report. You have to
No, but the slides come without even some wrapping or anything. They just come blank.
they come in a paper, folded in a
Paper, folded paper. Okay.
Even the slides are stuck to each other because 5 are inside without anything.
Okay.
It's a terrible mess in Bombay. And I have
Alright.
failed to educate because the residents keep changing every 6 months. So it is a difficult situation, but
Okay,
try your
fine.
best. We keep doing that education.
Yeah, we'll do that.
Other question, Akshay? Any other question? Okay, fine. Dr. Richa?
Thank you, sir. Basu sir, it's always academic treat from you, and I thoroughly enjoyed your lecture. Thank you so much.
Thank you
Sir,
so
a
much,
simple
Richa.
question. How do you use Congored in your diagnostic marrows of myeloma? Are you doing it upfront in all cases or only when you suspect it on morphology, the coexisting amyloid?
Yeah, I do it only when I am suspecting or when there is evidence, not upfront on all the cases.
Yeah, I get a lot of requests, but I keep explaining to my clinical colleague that we'll do it when we see it, not really helpful in all the cases. And second thing, sir, if I'm allowed, we also had similar problem of formalin fumes and marrows not being wrapped up properly. The solution I found is involving lab technician in marrow. It may not be possible to send pathologists everywhere, but if they have practice of calling a lab technician every time they are doing a marrow, who can be trained, who's a permanent lab staff, and that gives us a lot of happy space in getting good process slide and then reporting them well.
Fine. Right.
Thank you, sir. Thank you.
Thank you.
Dr. Richa, can I ask you the question again? What was your first question about that amyloid?
Sir, actually, we get a lot of requests that in diagnostic myeloma marrows, if we can do amyloid testing upfront, like all Congo red. But we usually do it when we see morphologically. So that is what I wanted to understand from sir, his practice.
In the sense, if you don't have plasma cytosis, then you don't do.
Sir, if I'm not seeing any amorphous eosinophilic hyaline material, it's entirely just the cellular marrow with plasma cells, then I usually refuse the congruent test.
Got your point. Thank you. Yeah. Okay, Ruchi.
Thank you, sir. I had one query. What is the significance of lymphohistiocytic aggregates in a bone marrow biopsy? Suppose we are not seeing granulomas, but we are seeing some aggregates of lymphohistiocytic clusters.
Yeah, clinically, you will have to correlate. If you're looking up for maybe a PUO or trying to find granulomas, they will be significant. Otherwise, histiocytes and can be a part of routine thing. But if you are seeing a cluster of lymphohistiocytic and you have to give maybe more sections and do a stain for AFS, though again, both your AFS and other histochemical stains on a decalcified marrow doesn't work out as well. So it depends entirely on the case, I suppose. If they are significantly in number, then yes, why not think of a granulomatous inflammation? Or you might get that in hemophagocytic lymphohistiocytosis. Depends on what the case is. You have to give it significance.
Yeah. And one more thing, sir, sometimes in cases of biopsy with, when we do it staging for Hodgkin's lymphoma, we don't see Reed-Sternberg cells, but we see a background of histiocyte, eosinophils, plasma cells. So till we see a RS cell, we cannot call it infiltration by Hodgkin's.
No, depends on if you were to look at how Hodgkin's was reported in the earlier days and how guidelines were there. There are entities like definite or suspicious. So in all those cases, when you're not finding a classical RS cell, take step sections, and if necessary, do a CD30.
Okay. So
But if your milieu is classically milieu of inflammatory cells with fibrosis, you can even call it suspicious of Hodgkin's. That is how it was recommended.
So is there any terminology which exists, which we call it Hodgkin-associated changes?
Yes, you can.
So it is not infiltration, sir. Is it just a part of the disease?
That is difficult to really say. Ideally, it is when you see that, if it is just a diffuse kind of a process, eosinophilia and all, that could be Hodgkin's associated. But you are seeing a localized cluster where the milieu is there, inflammation is there, fibrosis is there. You have to go out all to identify a Reed-Sternberg cell.
Okay, thank you so much, sir, for a wonderful presentation. Thank you.
Ruchi, I would like to remark here, because it has such a major consequence for the patient and the clinician. In such cases, it's invariably to be confirmed by whichever lymph node, however difficult it may be at a difficult site or small in size or low SUV value, it has to be proven by a lymph node biopsy or some organ biopsy. So however, maybe the maximum suspicion from the bone marrow, but if it is suspicion and not confirmed, then if we are not able to get any tissue or lymph node, we'll rather wait and watch. Few weeks later, repeat a PET scan, see that some lymph node comes up, which is possible to biopsy, and then do a true cut biopsy of that. We will not either say no or yes, that there is Hodgkin or no Hodgkin, and not start the treatment.
Yes, I was thinking that you are talking about a known case of Hodgkin's. If it is not a known case of Hodgkin's, you have to be 100% sure that you're dealing with Hodgkin's.
Ruchi, you are muted. Ruchi, muted.
Sir, I was talking about known case of Hodgkin's lymphoma for staging. We already know a person has Hodgkin's lymphoma. It has come for staging, but we are not seeing classical Reed-Sternberg cells on morphology. But the background milieu is like that. So there we are stuck whether to call it infiltration or not.
Yeah, then it's relatively an academic question, because it doesn't really matter much. Today, PET scan takes care of it. So
PET scan nowadays will take care of. That's it.
Thank you so much, sir. Thank you.
So thank you. And there are no more raised hand sign. If anybody wants to ask any last question.
Sir, I have a comment to make.
Yeah.
If there is a milieu there in a suspected case of Hodgkin's, a simple IHC for CD30 might help. And if there is a radiological evidence.
Dr. Basu just said that, yeah. CD30, yeah. So, yeah, we have completed it. Dr. Basu, thank you so much.
Thank you so much.
You are really like a Bhishma Pitamaha for this particular subject.
Not really.
Absolutely.
No, no. My Bhishma Pitamaha is Tejinder Singh. I don't know if sir is listening.
I agree. Tejinder Singh when I was young, and when I'm old now, you are there.
No. I cannot replace them at all.
You have probably helped hundreds of participants who have logged in, and there are 30 to 40 over here. Phenomenal. Is there anybody from Intas to give the word of thanks? If no, then okay, I do this job.
Yes,
thank
sir,
you, Dr. Basu. Thank you, all the discussants. Thank you, the audience. And thank you, our event management team. And of course, our chief guest today. So wonderful. Go for your match. Have your dinner, lunch in between. And let's hope India wins. Bye-bye.
Yes, thank you so much.
Thank you so much.
Thank you, sir. Thank you.
Thank you, sir.